everyone. Welcome to Public Health Grand Rounds at the Aspen Institute. We are really thrilled to have you here for this very, very special fall session. I am Ruth Katz, Executive Director of the Health Medicine and Society Program at the Aspen Institute. Health Medicine and Society is the founding and ongoing sponsor of Public Health Grand Rounds. As many of you know, Grand Rounds is a time-honored feature of medicine designed to keep clinicians up to date about scientific and medical advancements and to promote excellence in research and practice. Public Health Grand Rounds borrows from that tradition to advance knowledge about the cutting-edge public health or population health matters of the day. None could be more pressing or of greater interest to us all, especially at this very moment, than the various issues, challenges, and policy decisions taken on by the Centers for Medicare and Medicaid, or CMS, as it's generally known, an agency within the Department of Health and Human Services. As the nation's largest public health insurer, CMS shapes the care of 160 million Americans. It has an enormous portfolio of responsibilities, including activities related to Medicare, Medicaid, the Affordable Care Act, private health insurance, and so much more. To learn about all this, we will hear today from the guy who is in charge, the guy at the very top, the leader of the agency, and we couldn't be more pleased to have him with us to share his vision and priorities for CMS and the agency's role in improving healthcare access, quality, and outcomes across the country. Dr. Mehmet Oz serves as the 17th administrator of CMS. A heart surgeon by training, Dr. Oz is also a professor emeritus at New York Presbyterian Columbia Medical Center. In addition, he is the founder of a national nonprofit which emulates the Peace Corps by placing recent college graduates into high schools around the country to teach diet, fitness, and mental resilience. He is the author of 8 New York Times bestsellers and has been recognized for his decades of work by Time Magazine, Forbes, Harvard University, and AARP, among many, many others. Dr. Oz is also the recipient of tons of awards, ranging from 9 Daytime Emmys and a Hollywood Walk of Fame star to the Ellis Island Medal of Honor. In conversation with Dr. Oz is Bertha Coombs, senior healthcare reporter with CNBC, where she covers healthcare services and policy, as well as financial markets and business stories throughout the business day. Before joining the network, she reported for the pioneering streaming business network Yahoo Finance Vision. Prior to that, Ms. Coombs served as a reporter for ABC News 1 and a substitute anchor for World News Now and World News This Morning. I got it right. Thank you both for being here for what promises to be a very thoughtful, timely, and clearly very important discussion. And a reminder to everyone as we get ready to kick things off. We have all come here today to listen and to learn from one another. That is what Public Health Grand Rounds is all about. To that end, while we acknowledge there may be differences among us, it is imperative that we respect those differences, try to understand and gain insights from them, and hopefully together move forward in helping to achieve the goal every one of us wants and shares: good health for all. Now, before turning things over to Bertha, a few housekeeping notes. First, as I think you can see, we are videotaping today's program. It will be up on the Health Medicine Society website within the next 24 to 48 hours, so you can watch it again and again and again. Or share it with friends and colleagues. Our interview will run for about 40 minutes or so, after which we will open the conversation to take your questions and comments. Please wait for a microphone before speaking, and then do introduce yourself and state your affiliation before asking your question. Finally, I say this every single time, please, 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 time is tight for the Q&A portion of the program, and we want to get to as many questions as we can. So please be brief, get to your point, get directly to your question, so that we can take as many as we possibly can. With that, many thanks again to Dr. Oz and to Bertha Coombs for taking time from their really incredible busy schedules to participate in our Grand Rounds program. Also thanks to Katya and Hugo of the HMS staff, as well as the CMS staff, for all the logistical help. And of course, thanks again, you all too are very busy people, for taking time from your schedules to join us today. Again, it's great to have you here. And with that, Bertha, the Aspen stage is all yours.
Thank you so much, Ruth, and thank you to everyone at Aspen for inviting me to come and speak to Dr. Oz. I've been very excited about this. And I want to start out with something someone told me. Given your extensive resume, you're a cardiothoracic surgeon who has saved countless lives, and yet someone said that you expressed the feeling that this was the best job you ever had.
Well, without question, and I have had wonderful jobs. I love doing heart surgery. In part, you do of course, the part that they would often call cool on television, but the part that's best about being a surgeon is you get to look people in the eyes before you enter in the operating room, and every single day you feel rewarded because they trust you, and you need to deliver on that trust. So that job was fabulous. I love training residents. I ran the Heart Institute, the cardiac labs. These were all wonderful experiences for me, but I began to realize over time that much of what we were talking about within the ivory tower of Columbia wasn't really understood by the average patient coming in through the front door. And, partly because of my wife, who's been a real influence. We've been married 40 years this summer.
Congratulations.
In my house, the prosecution never rests. So she can be tough. She's getting her PhD in Jungian psychology now, I think primarily so she can target me on my multiple flaws. But she said, America's not getting the message because people like you aren't giving it to them. So I started to do more television, media, frankly, just answering the phone when people would call and ask for a thought on some event. And I would encourage any doctors watching today to pick the phone up when media calls. I think many physicians have felt like we've lost our mojo. Our voice doesn't seem to matter as much, but we are professionals, and like all professional classes, you are the ballast of the ship of society traveling in the troubled waters. You have to be able to opine on issues that are sometimes complicated and controversial, and you don't want to get plenty to do, so I get into the middle of this, but if you don't express an opinion, society suffers. So I began doing television, and over the years, hosting my own show and appearing on other shows, I gained a lot of understanding of how you can message complicated ideas. But I always would remind my team when we would make shows that ultimately a doctor is trained to give bad news to people, even when they don't want to hear that bad news, but still have respect and passion and compassion be part of that, which is why people ultimately will listen to their doctor. And in countries where they don't tell you you're dying of cancer, well, the patient thinks they're always dying of cancer because you wouldn't tell me if I wasn't. And so you actually take fear away by being honest and telling people what you think is happening. And CMS combines all of those attributes. You do get to play a role in people's lives and be supportive of them. You have a team to work with, and I must say that one of the reasons this job is so great is that the staff at CMS is unbelievable. Not just my inner staff, who are great, but there are 6,500 people who work in the agency. There's 40,000 contractors. These people have deep domain expertise. But if you actually get into why they're there, most of them gave up really good jobs on the outside because they felt a commitment to public service. They thought they could make a difference. And so many of my folks in the private sector where I came from, their vision of their government employees is the sloth in Zootopia. There's like slow motion, nothing's really moving, it's all gummed up. That's not what happens. You are going as fast as you can every day, trying to absorb as much information and make decisions based on as much data as is available. I also like serving in this administration. President Trump is an excellent leader. He understands that you need freedom, that sometimes it's not going to go perfectly. He sets an agenda. He will call you up frequently if he doesn't see the agenda getting advanced. So you better make progress. That's actually very stimulating to the team because President called me, not happy about this, and he marches, like a good manager. He is observing continually, and I think many of the wins that we've been experiencing have happened because he's pushed us to use the power to convene, to pull together private sector groups who normally wouldn't maybe be talking to you or certainly wouldn't have felt included. And we'll call them up and say, we've got a major problem. We've got a catastrophe with prior authorization, and we need to deal with this. So I could pass rules, I know how to get legislation, but those aren't going to be very nimble. If you want to fix the problem, then maybe you can get ahead on this. And so we did that actually, as you know, with getting the insurers who cover more than 80% of Americans to think differently about what prior authorization could look like. And we can go into the details later, but succinctly stated, they actually know how to fix their business. And they sort of wanted to do it, but they needed to be protected a little bit. They need to be urged, and the people who want change need to be supported so the people who don't want change feel compelled to go along with that. And so the industry begins to reshape what it wants to do. We're seeing that now with the most favored nation drug pricing, which I'm sure you'll have questions about. So all of these are opportunities for us to re-envision the way the government normally works, not based on litigation slowing everything down, but by leapfrogging litigation, if possible, to get people to do what they probably want to do and should be doing anyway.
Terrific. One of the things that makes this job challenging is, in a sense, we are right now in a public health emergency, given that the government is at a standstill with the shutdown. And one of the issues at the heart of that is the enhanced tax credits for the Affordable Care Act marketplace and members there. The numbers are big. The Kaiser Family Foundation says we are seeing an 18% median increase in premiums for next year because insurers are thinking that it's not going to happen. The Aspen Institute says that more than 7 million, nearly 7.5 million people would lose those tax credits altogether if they're not advanced, and nearly 5 million of them probably wouldn't be able to afford coverage, so they would wind up being uninsured. And big states like Texas, Georgia, South Carolina would see about half of their members not be able to enroll. One of the questions I have for you is, given the tight timeline, the shopping period begins next week on the 15th. That's when people will see the premiums for 2026. If those premiums go live at that rate without enhanced tax credits, and you would have Congress pass them after the facts, perhaps after November 1st, is there anything that CMS can do to somehow roll back some of those increases?
There are things CMS can do to make sure that the out-of-pocket expense of Americans is not impacted in accordance with whatever legislation is ultimately passed. But you start off by saying something that's very important, and I do agree. It's a public health emergency. You do not want your government shut down. The people who would help me, the folks I've been bragging about who have domain expertise and understand a lot about a complicated marketplace. The ACA is not just about public subsidies, it's also about the private sector, being able to provide support to some of its employees. That's stuff that you need people who spent their whole life embedded in the area opining on. They're not at work. I came from CMS. We have some people, but we don't have all the people. And so the people who aren't there are the ones that we would crutch on to be able to figure out the best path forward. So and even if we wanted to do it now, you don't want to make a decision of this importance in the middle of a shutdown when folks aren't at work and there's a lot of vitriol going back and forth, which is why we need a clean, continuing resolution, keep the government funded for the 6 weeks it might take to work through some of these issues and get folks back to work. I actually thought that would happen. This is my first stint in government. I should probably ask you, Bertha, what you think is going to happen, but it just seems like something we would all want to do, so that we can actually roll up our sleeves. And we've been thinking about this for a long time. It just needs to get on the front burner, and it's definitely there now.
But the timing of, if that were to be passed after open enrollment begins, what can CMS do? Can you roll back some of those premium increases, which insurers put in essentially as a preemptive measure, thinking that not that many people are going to sign up, and those who sign up will be those who are sicker and will utilize more?
So the actual premium rates that the insurance companies are setting were already set last month. They're already in and they're baked in.
So those can't be
changed. But
back.
That's not really the pain point. The pain point is, what do you as a recipient of the Affordable Care Act have to pay? And that number we can adjust so that it's in accordance with what you think you can pay. Obviously, it'd be nice to do that before the end of this calendar year, because you start having to pay those at the beginning of next year. But I also want to go back to the numbers you shared, because this is a really critical issue for folks to get clear on. I'm just going to give you the data. I'm not even going to try to spin it in any way. There's a little over 23 million people right now on the ACA. Half of those people last year did not file any medical claims. Now, not everyone files medical claims, right? Maybe the normal number is 20% of people who have insurance. But if you pay money for insurance, you do tend to use it. So when half the people don't file any claims at all, And we know that there are millions of people who don't even know that they either have the insurance or they have multiple levels of insurance. That raises major concerns. So I'll give you two concrete examples. There are quite a few people who the first time they realize they have the ACA exchange insurance is when they get a note from the IRS the following year telling them that they got a tax credit. Well, for what? I didn't buy anything. They never knew they had insurance.
How prevalent is that?
You know, we don't know for sure, but we think if you add all of them up, it's over 6 million people. And I'll tell you one number we know for sure, the amount of money that we spend for people who are on Affordable Care Act policy and Medicaid in the same state. We're not talking about different states. That's a much, different issue. But just within the same state, that was probably costing us $12 billion a year last year. So these numbers are quite large, but the fact we don't know that exactly is also concerning to me. So some of the reasons the premiums are going up is because if you take people who didn't know they have insurance and therefore never actually put in any claims off the rolls, then you still have, people who are in there where charging enough to make up the difference because the total amount that you paid out doesn't change. But I do think that there are criminal elements. There's Department of Justice cases that have been won against brokers who have gamed the system. And especially if you're looking at some of the ways policies were issued, if there's no way that I have to get you to give me any money at all, even $1, then I really don't know for sure if you have a policy. And these are the kinds of things that complicate issues. But I want to create a marketplace that's vibrant. And the way that Obamacare was initially, the ACA was initially designed, it was supposed to be 50% subsidized folks from the government because they need help, and 50% private sector people saying, hey, this is a pretty good deal. Instead of buying the traditional insurance that companies would offer in the commercial marketplace, I'll just let them use this government ACA plan. They're still paying, but they're paying into a different model. And states had individual examples of that. But up where, New York, Massachusetts, New Jersey, the West Coast had some. So there were different options out there. Those were all replaced. But the marketplace as it's functioning now, I don't think delivers what its promise was. And again, you can't figure that out in the middle of a government shutdown where your key allies are not at work.
How would you make it work better and not effectively disenfranchise people? Every time we have these rule changes, a lot of people fall off the rolls.
Well, we don't want people falling off the rolls. There's a quote as you walk into the entranceway of the Humphreys building. Have you been to the building, by the way?
I've not.
It's a little bit difficult to look at. It was built during the brutalist. There was actually a brutalist architectural movement in the 70s. And it looks like it's a prison, but it's actually quite nice on the inside. But there's a quote from Hubert Humphrey as you walk in. It says it's the moral obligation, responsibility of government to take care of those, and uses light as a metaphor, take care of those at the dawn of life, the children, take care of those at the twilight of life, the dusk, the seniors, and those who are living in the shadows. It's a haunting metaphor, but I think it's appropriately describing. The folks that we're trying to help, both in Medicaid and in the exchanges, are folks who with a little bit of help, they hope they can get healthy and be able to take care of their families and move on. We want to provide that. But these are topics that tend to draw on lots of different moving parts. And oftentimes these populations are young and healthy, and they don't think they're going to get sick, so they don't really want to engage in an insurance offering. Sometimes they're older and they're not on Medicare yet, so they tend to be expensive. They're the ones you want to help in particular because they're the ones that have worked their whole life, but they're starting to run into problems sometimes. So there's many options. I could recant them to you, and you can get into the nuances of the nuance. But at its very core, you do need both parties working together on it, and you can't get there while we're stuck. And that's the part about this whole process that is interesting, because if you boil it down, the continuing resolution, and this is not political, it's just a statement of fact, continuing resolution keeps the government open for 7 weeks. It's not some long-term strategy. So you're also creating a deadline for 7 weeks to figure out some of these issues. And anyone who signals anything right now is creating confusion. So the most important thing I think for us to do, all of us, is let the water still, let people see more clearly what we're really talking about, and get the continuing resolution that has already been passed by the House through the Senate, get the government functioning so my team can come back, and then let's get serious about some of these issues and what's the art of the possible to help the American people. If we focus on quality, ultimately, we will almost always thrive. The single most expensive thing, Bertha, and I know I've been told you have some experience with this, which we can get into if you're comfortable sharing. And we never talked about this before, so I don't want to put you on the spot, but most of us have horror stories in our lives of things that didn't go ideally well. But the most expensive thing in healthcare is bad coverage. Bad healthcare, you pay the person to do a bad job, then you pay another person to fix the bad job, then you pay for the complications of the bad job. And so the process is much better if we can get ahead of that and start dealing with quality metrics. And much of the digital transformation that I suspect you'll be asking me a bit about, our effort to try to do in healthcare what we already have in banking and Uber Eats and digital streaming, just bring technology that's helping us customize care and thoughtfully provide the best service possible. It's harder to do in healthcare, but it's definitely doable in healthcare. And now that we have agentic AI that is, it's sophisticated enough that I'm beginning to trust it. And I'll give you an example. I had a conversation with agentic AI avatar, big hospital system that has been using it, shared it with me. So I was playing with it, and I pretended that I was a diabetic who didn't care about myself. And so I gave answers that made it feel like I was a little down in the dumps, that who cares if I take my glucophage or my insulin, and it picked up on it. It said, by that answer, I'm beginning to think that you don't realize how important this is. And your creatinine, I was fictitiously, my creatinine was 2.5, and if you keep it up, predictably in 9 months, you're gonna be in renal failure. I mean, you understand what that really means? That level of discussion often doesn't happen because we don't have enough primary care docs, especially in rural areas where we're struggling. And so if I can start to use some of these tools, not to replace doctors and nurses, but to augment their services, those start to improve quality in ways that actually move the number. Because what I don't want to spend my whole 4 years doing is rearranging deck chairs in the Titanic, trying to come up with more money to pay for this and that. The actual reality is we spend twice as much as any country on the planet for healthcare. And that's not because people are taking advantage of the system, I wish it was that easy. It's just an inefficient process that we have tolerated. And there was a marriage recently in the family, and the family that was marrying into our family was a prominent family, and the patriarch of the family got up and he said, for the first time in our family's long and illustrious history, we finally have a doctor in the family. He wasn't kidding. There's a major advantage if you have someone like that you can crush on, a nurse in the community. All those matter. By the way, before I forget, this is a sidebar, but it's an important one. We don't have enough nurses, obviously. And we have, it turns out, because of the way that civil monetary fines are imposed on nursing homes that are having problems, we actually have a corpus of money, about $75 million. And we are challenging all the governors who also have money from the same fund to match us. And we want to create a couple $100 million fund to train nurses around the country. Now, you'll be hearing more about this, but I only bring this up because it's the kind of thing we could do together. And, I'm putting our money up on behalf of the federal government. They'll match Democrats, Republicans. I'm speaking to governors all the time now because of the Rural Health Transformation Fund. They want this, and we could train nurses. The best part about training nurses at local community college, LPNs, is they tend to stay in those communities. Now you have a health professional in the small town you live in that you could just get curbside consults from. I think we can do the same thing with pharmacists. Pharmacists do not work at the height of their licensure. Think about that. You go to a pharmacy school, you're not there to dispense pills. You have a lot of stuff.
Pharmacies have been trying to do that, but at the same time, because they're under pressure, it's again, everyone always says about healthcare, you push on the balloon on one side, it pops out on the other, because this is a very complex system.
So Bertha, in our mindset, part of the problem has been people on my team have been slowing it down. My team being doctors, right? Because we don't want to give up control. So the $50 billion Rural Health Transformation Fund, that was part of the One Big Beautiful Bill, forces this conversation. The president and the Senate very thoughtfully said, Oz, give the money out by the end of the year. Don't hold on to it. Governors are the ones who know what's best for their states. Trust them with that money. So there's a grant process. notice of funding opportunity. Those grants are coming in by the beginning of November. We're going to allocate the money by the end of the year. We're going to ask governors, that's a very concrete example. We want them to evaluate the licensure of pharmacists and free them to be able to provide great services. I mean, think about the scenario. You're a 28-year-old woman, you work in a facility that needs you back at work at 7 in the morning, and your kid gets a sore throat at night. There's 45 miles from you, there's an ER. They can figure out if the kid has strep throat, or go to your local pharmacy where there's 60,000 pharmacies. There's many more pharmacies. There's at least 12 times more pharmacies than hospitals. So just go to a pharmacy, get the pharmacist to do a swab, that's a strep test. Doctor can adjudicate if the right treatment is penicillin. Penicillin's right in the store. Give the pill to the mom. She's back in bed by 10:30. The child's sleeping comfortably. Skips a day or two to school, but didn't have to get dragged across the state to get tested. That's a good use of our healthcare resources, and it's a lot cheaper than paying for an ER visit.
I would argue that a lot of that is already happening between telehealth and with a lot of these pharmacy chains that have been able to do that.
It's not scaled. It is happening, yes, you can do it. But even telehealth's being held up by the shutdown.
Exactly.
But a lot of folks don't have confidence in the longevity of these issues. We should codify these. This should be part of what we do going forward. And you can bet on it. You can build businesses around it.
Speaking of telehealth being on hold because of the shutdown, let's move on to Medicare Advantage. You had once really thought this was the solution and that it should be Medicare Advantage for all, but now you feel like it's upside down, and you have looked to try to right-size things and do real-time audits. At the same time, we just had a court ruling that overturned something the last administration tried to do for risk adjustment data validation, a new rule to try to recover overpayments more quickly, and the court said no, that rule wasn't adjudicated properly. As you're looking at these issues, there are a lot of hurdles in terms of regulatory hurdles to try to do what you want to do. Where are you right now as you try to move towards these real-time audits, and do we really have the technology to do that?
I love when people understand healthcare. Thank you. No, these are great questions. I heard wonderful things about the grand rounds, but it's good to dive into some of these details. Maybe I can get some insights because you'll learn a lot from questions. So the RADV process, the audit process, has been held up. We think we can re-navigate that. There are reasons why the courts felt the way they did, but the bigger message that we're sending to industry is that Americans need choice. We believe fee-for-service Medicare has opportunities especially if we use the accountable ACOs, the accountable care organizations, which can bring a little bit of a mindset that is an MA, a little bit more competition, but taking on risk into that model, which is happening and growing quite nicely. The MA is now 54% of America, Medicare Advantage. So you have access to both in most parts of the country. There are exceptions where it's a little unbalanced, but generally speaking, you can pick one or the other, depending on what your personal needs are. There is some data that Medicare Advantage plans do provide better quality care. You don't have the need for supplemental insurance, so there's a bit of a cost savings to Americans for whom that's very important. There are other things that they can do as well, but we have been concerned that it seems that Medicare Advantage plans cost more to the federal government than fee-for-service Medicare, and that shouldn't happen.
Although they will argue that it doesn't because they provide better care when you look at it on a larger scale.
Which is why the preamble is always that, because it's not fair to them to say you cost more. You're giving more. You have an average $200 per member per month of supplemental benefits that come out of the money that you theoretically save by charging 82% of the fee-for-service benchmark. There's monies that can be harvested and used, but are they used to the best purposes? I don't want you buying kayaks with that money. That's the American taxpayer that subsidized this process and got it going. So let's be thoughtful about how the money's spent. But this is a good example. So we have a couple choices. There's lots of energy in Congress to take legislative action. It's really easy to beat up on the MA plans. They happen to be owned by insurance companies that aren't so popular either. So you have that path. There's regulatory opportunities for us. The first often tends to be maybe draconian and take aggressive stances that need to be more nimble, but you don't have that context sometimes. It's difficult you can't just write the laws. The Congress and the Senate, Congress and House and the Senate write it. So whatever comes out, you got to deal with it. The rulemaking process is prone to litigation, but is a possibility. There's a third path. So we have met with the big MA players, Medicare Advantage players, and together, and we said, this industry, we believe, is challenged. And you're here, all of you, because you are concerned about some of the things going on as well. So if we gave you a little bit of space with an understanding that we have regulatory opportunities here that we will use, tell us what you think would work. Now, I understand you're self-serving. We're guarded on that. You should be self-serving. You're running a company. But I've asked them and many others to do something that's talked about in the Bible, which is to be meek, right? So, but it says the meek shall inherit the earth. When I was a kid, I didn't really know what that meant.
Well, you're talking about CEOs. I don't
Exactly.
think, by definition, they're not going to be meek.
No, but what does the word meek mean? This is where I struggled. So I thought it meant weak. That's not what meek means. Meek means you're incredibly strong. You have a sharp spear that you could use to do real damage to everybody else around you. And you decide, you feel, because you have the empowered ability to make this decision, that you're not going to use that sword. You're going to sheath it, put it away, and be meek, just so you can figure out an answer. Humans tend to be able to do that. You don't want to waste a crisis. So when the industry feels incredible pressure on them, and they know that we have an opportunity to come down hard, I think it's worth a shot. Now, it's not going to be a long shot. These decisions have to be made by the end of this calendar year, sort of what we did with prior authorization, which had some overlapping players. Just with prior authorization, I want to just describe this. This is a great example. If you already thought about this, you wouldn't need to do prior authorization. The doctors should be so good, the procedures and protocols so clear, you should never need to second guess or litigate whether a patient gets a care. I mean, I'm coming to see you as a doctor. You're telling me something, that precious moment, that covenant that a doctor and a patient have together. You tell me something you think I should do. I don't want to have someone else that I've already paid, for, an insurance company, reach in and grab that away from me. So I'm respectful and understanding of that. And they actually sort of get the picture. They don't want to be in that spot, but it does turn out that it takes about 20% of the cost out of the system, much of it legitimate. But we went around and we looked at best practices. Kaiser doesn't have prior authorization. They just don't do it. They go to the doctors at the end of the month, whatever.
But they're integrated, and their doctors are working with the insurance company.
Good. So I knew that. And I thought, well, okay, that's not quite example. But let's look at another sample. Allegheny, Highmark in Pittsburgh. So they have a gold card system, which means if you're one of the 50% of doctors who seems to practice in a way that's consistent with best practices, I'm not going to check anymore. At the end of the month or year, I'll come in and, you did 2 extra back surgeries you didn't really need to do. Can you explain what happened? Well, that's okay. Or next year, don't do it. Or if you do it a lot, I'm going to take you off the gold card. Now what happens? All the doctors want to be gold carded. Mm-hmm. And by the way, if you don't have a gold carded doctor, that's a concern by itself. And then I learned something else. And this is the fascinating part about this job. There's 15,000 procedures. About 6 of them get used, but they're not the same 6. Insurance companies pick different ones. It's crazy. So I said, can you guys just figure out which ones matter? Maybe it should be 1,000 out of the 6,000 or 3. Pick the number. And then when you have that number, tell me what the actual answer is to the question. Like if it's a knee operation, is it 90 degrees, 130, 180? Like how much can your knee bend to justify surgery? If that's the metaphor for quality. So write it down and let's adjudicate it. If you actually can pick instead of 6,000, 2,000, and then give very concrete about what yes it's approved looks like, it's like a bank card, a debit card. You go to the bank, you put the card in. Behind the scenes, the banks all work this out. Like the insurance companies should work it out. I should know immediately if my card worked and if I have money in the account. The vendor should know with assuredness that that's the case as well. And then we get out of the way. Then you're not playing in there.
But we've heard them say this before. We've heard actually insurers say they have a gold card system. A lot of times, most likely their own doctors that they're doing it for. And we've heard all these platitudes before, but in reality, it doesn't work out that way, whether it's for the patient or for the doctors who still feel like they are on the treadmill. And now we have doctors trying to use AI to solve the problem, and then the insurers trying to use AI. So you have, instead of people on the phone, you have the AI bots battling one another for the same issue.
We gave them till the end of this year to figure out what were the procedures they wanted to have codes on, and by the end of next year, they have to have immediate adjudication. So they can tell as soon as you file whether you get it or not. They may not be at 100%, maybe it's going to be at 90%, but the vast majority should be done that way. They actually argue, very interesting feedback, that most doctors, 49%, remember the number, 49% of doctors respond to prior authorization requests with paper because they don't trust the system. Doctors have digital records, they don't want to share them. So this is part, again, this larger landscape we're building of digital health transformation. And this is not because we're such special human beings. We finally have technology to do this. To your point, it's being weaponized. This happened in banking too, by the way. The fraudsters used AI to hack the system. The banks began to use AI to block it. It turns out we have an advantage with AI. You know why? Because we don't think the way fraudsters think. That's not what our minds do. Like when bank managers don't think about bank fraud. They want to do loans and help businesses get on their feet. Fraudsters think about fraud. So the AI can think the way a fraudster thinks and is better than a manager at blocking it. The same is happening within healthcare. We're stopping, like the big bust, the $15 billion bust we did with the DOJ last month, maybe it was 2 months ago. That was, again, $2.9 billion left the door. It's gone. But the other $15 billion, the remaining amount, $12 billion, we kept. So we're getting better, and we actually are getting more aggressive, and you'll be hearing more about the Fraud, Waste, and Abuse Initiative. There is no way for government to be as good at fraud detection as AI will be at fraud detection. But if we have it, we can use it, and I can use it on these insurance companies as well, because if we see that they're not following the metrics we've designed, they already know that we're basically holding back, that we actually have everything's loaded, ready to go, and just like we did with MFN, most favored nation pricing, if you set up the gauntlet the right way, there's enough issues that could come true and make your company suffer, then they don't want that to happen either. They want to be in business. And the basic story is you want to have a great business, unbelievably good profits for a year or two, and then be crushed? Or do you want to have a business that's sustainable for a generation because you're on the right side of the decision process? And I'll tell you a line that sort of does work, and you can be skeptical about it, but I've used it and I see it. Most people went into the health space because they care about people. Now, along the way, you forget that. Doctors forget it too sometimes, but insurance, CEOs, pharma CEOs, at their core, they had some inclination. If you pull them back and say, you're going to be judged by how you make these decisions, you get to open some doors. What we did last week at the White House with Albert Bourla from Pfizer, it was remarkable. Like, they didn't have to do that. We didn't pass any laws, we didn't put any regulations that would be directly harmful. We created a series of issues that they knew we could use. But at its very core, it was us looking in the eyes, and Chris Klump, John Brooks, a wonderful group, Inma Hernandez, did the heavy lifting on this. They worked day and night with these pharma folks who for the first time said they really felt like they were talking to people who knew their business as well as they knew their business. So you couldn't game it.
Well, I want to get into that, but I have one more question about Medicare first. I spoke with the head of one of the largest Medicare Advantage, or in fact, the largest Medicare Advantage company here in the US, and he was saying that this is really a critical, pivotal moment for the program. You talk about sustainability. In essence, we're in the third year of a regulatory shift to try to right-size reimbursement. Yep. At the same time, they are seeing more Medicare patients utilize more. Some of it may be people having put things off from COVID, and so that is all coming to bear, not to mention that prices have been going up. So although the headline is that most Medicare Advantage plans will see their premiums go down, and there will still be many that will have $0 premiums, mostly HMOs as opposed to wider network PPOs, people are going to see higher out-of-pocket costs. And a lot of people think that this open enrollment, when it officially starts next week, you're going to see a lot of friction and people really feeling confused about the fact that you're seeing so many companies pull back on plans, decommissioning plans that they don't want people to enroll in, and also raising prices on the back end. How do you make this more sustainable? Again, you want to crack down, you want to have better payments, but it always results in this kind of friction and upheaval.
That's why the president asked me 3 times if I really wanted the job, because he knows these are challenges. Commercial health insurance rates, which I don't regulate, are going up almost 10% this year as well. So it's not just Medicare. Across the board, we're seeing utilization of resources that's above what was expected. The prices of care are going up. Hospitals are more expensive, salaries are more expensive, pharma prices have gone up. There's lots to be concerned about. But here's why I'm an optimist. First, I actually believe that this is it's like moving a ship. You may think we're on the Titanic, I don't, but this ship has to move, and it's got to move at a pace that people can keep up with. So the decisions that we're making today are going to impact the market next year. And much of what we're doing, like the most favored nation drug pricing, could begin to pretty quickly make a dent in some, more than other, but some areas. Like Medicaid in particular is going to be in a better spot. Now, I know Medicaid, as everyone's talking about Medicaid in the One Big Beautiful Bill, but all of the drugs we believe in Medicaid, certainly from all the companies that we're going to be bringing in, and one a week is coming in.
But Medicaid already gets the cheapest price of any program.
They don't get the cheapest price. They get the cheaper price than other American programs. They don't get the cheapest price in the world.
No,
Yeah,
but within the U.S.
Within the U.S., they're better priced.
That's the lowest price.
But those patients use those products, and they're expensive, and states have to crowd out education and social services to pay for those medications. So when these companies come, and they don't have to do this, but they have agreed to voluntarily price their Medicaid products at most favored nation pricing, because it's hard to ethically justify charging to Americans who don't have resources 3 times the price of the exact same drug to affluent people
Well, let's
in Europe.
talk about, for example, the GLP-1. It's list price here at $1,000. You can get it in Britain for, I don't know, $200. So now in Medicaid, they'll get it for that $200. But what often happens, again, you press one side of the balloon, it comes out the other side. So Medicaid will get it cheaper for that diabetes GLP-1. Medicare might pay a little bit more, but then those of us in commercial plans end up having to sort of pay the difference, because these drug makers have to make a certain amount of revenue to recoup their investment.
So that's not what's happening in the Pfizer deal. I can't talk specifically about any of the upcoming ones, but we have a vision that would probably align with what you would want, which is to not have the balloon bulge in one area because we're pushing in another area. There are some places that we are going to get incredibly discounted prices. Others will have less, depending on the category of medication. But here's what I'm solving for. 2 issues. One, Europeans in particular, but other affluent nations have been freeloading, global freeloading in general, on U.S. pharma prices. So we pay, we're 4% of the population. We're responsible for 60% of pharma profits. We have a nation where many people go to the pharmacy, about 1 in 3, and can't fill their prescriptions if they're brand products because they can't afford it. They're choosing between groceries and medications at all income levels. The need for us to push other countries, like NATO did, to say, listen, you have an external threat. So you need to contribute to that. We'll pay. America benefits too, we'll pay, but you got to chip in. But we have internal threats. If you live in America and you have an advanced cancer, your survival rate is dramatically better than in Europe. People don't talk about this.
But we get access to those drugs because this market will pay for it more. This is also the market where we have more innovation. And at this moment, people are concerned that we're going to lose that advantage between the cuts at NIH, which are not under your purview, but that more people are being basically courted to go somewhere else to do their research, and we might lose out on that longer term.
The reason we did these most favored nation deals the way we're doing them is focused on innovation. What I don't want to do is government-controlled pricing, dropping down what we pay today, but then we no longer have the treatments available tomorrow. The same day that we did the most favored nation drug pricing announcement at the White House, several hours later, the president had an executive order around children with cancer and the use of AI to accelerate their diagnosis and treatment. And you saw these beautiful children. I get emotional thinking about them. I mean, they've suffered that in ways they shouldn't have had to, but they were all there. And I talked to these kids about their different diagnoses. Each of them were alive because they had been given medications, cutting-edge treatments that were available because scientists were funded to do the work. So we don't want to dull the sharp edge of innovation in America. But at the same time, I think we can do better than paying 3 times more for the same product and then made in the same factory, in the same box, to show to other countries, and we're getting there. That's the cool part about this. We're actually, we are leveraging, we're leading into it. There are things that we're doing from a regulatory perspective that make it easier for them to make the right decision. But the opportunity for them to be part of the answer, if they have a counterparty who understands the game like they do, is very reassuring to me. And I think the same is true in hospital pricing, staffing, providing enough healthcare providers. Much of what we're doing, the Rural Health Transformation Fund, is designed to catalyze that same conversation in parts of the country that are really in trouble. We lost 150 hospitals in the last 10 years in rural America. We have a suicide rate that's 50% of the national average. Life expectancy is 3 years shorter than in other parts of the country. 20% increase incidence across the board of chronic illness, and there's no real vision for how to fix that. So by putting 50% more money in to rural health care than Medicaid currently offers, that's a big amount of money, 50% more
Although some
for 5
would
years.
argue that this makes up for some of the losses that will occur because of the OBBB, and particularly the cutbacks in Medicaid, which would impact a lot of those safety net hospitals in rural areas.
I'm going to wordsmith something you said because you're so perfect in your words. You're a true journalist. There is no cut to Medicaid. I know you know this, but Medicaid is increasing $200 billion in our federal expenditures over the next 10 years. So it's not that we're in any way cutting Medicaid. It's not going to increase as much as it could have increased. And I'm not even sure where that number came from, because we calculated out if we had not addressed the state-directed payments, the provider tax issue, and the work requirement, which I want to spend a second on because I think it's so critical as a high level, it would have cost us $5.4 trillion more in the next decade. $5.4 trillion bankrupts Medicaid. So when I first came in and first began to confirm some of my worst fears about the Medicaid program. Again, that's the program Hubert Humphrey was talking about as we walk into our building. I am not going to let Medicaid go down. And if you spend $5.4 trillion, eventually somebody does something draconian and no longer provides care to Medicaid patients. So I want to focus on the people it was originally designed for. To do that, we had to make some important decisions. Rural health rural health by itself gets 7% of Medicaid dollars. 7. Why? Because when Medicaid gets money put into the state coffer, who gets the money? The person who's closest to the trough. The big city hospital, well-connected, board members, the president, country club friend of the governor, right? I mean, we know the lobbyists. I mean, we understand the game. The money never gets to rural America. So the amount of money that $50 billion represents to rural America, which today gets $19 billion. So they get $19 billion right now. We're putting $10 billion more a year into the program. But the goal is not to just pay the bills. The goal is to get them to transform their system. I'll give you a concrete example. Big hospitals have healthy IT systems, they have specialists, they have reimbursement models, they've got good deals with insurance companies. You go to rural America, they don't have those things.
They have no leverage.
I could ask the big hospitals, as part of their nonprofit commitment, because free care has gone down a lot than what it used to be when they were made nonprofits. Part of your nonprofit commitment is to step out beyond your doors, the ivory tower that I worked in, and actually adopt these hospitals. You can't buy them. I don't want you taking them over. Adopt them, share your IT, share your specialists, develop a cultural relationship so their OBs can deliver babies safely, right? By the way, maternal mortality rate 50% higher in rural America. So I'm asking, every major hospital I've asked to has said, yeah, we'd be interested. So I'm hoping that with the Rural Health Transformation Fund, we're going to codify some of these relationships. There are some hospital systems that already have a bunch of smaller hospitals in rural America. That should be the routine. By the way, what you figure out in rural America, you can scale to urban America. Anybody who's underserved should be able to crutch on a stronger, bigger system. Why not? And we can actually make that easier. I wouldn't mind funding that. That's something that once that gets into the routine, normalized, everyone's going to expect that. But right now you have a lot of hospitals that were built in the 70s, and the Hill-Burton funding allowed that to happen. There were 200-bed hospitals. In areas where they can't afford 200-bed hospitals, there's no patients there. They now have 10-bed census, and these are true stories. 10-bed census with an actual census of 1. There's 1 person in the hospital, and they're usually someone who's being transferred home from another. What that really means, what does it tell you? That the people in that town don't go to that hospital. The people in that town who get cancer drive past that hospital, even though they may have been born there, to another facility 35 miles away. So either we make that hospital a real hospital and capable of dealing with these issues, which they could, with telehealth and the like, or you get them to combine with somebody else, but we can't manage that in Washington. The governor should be making those challenging decisions with people in those areas and figuring out paths forward. They need health care. They deserve health care. Their zip code should not be their destiny.
You talked about the work requirements, and the General Accounting Office recently looked at the Georgia Pathways Work Requirement Program, which was an 1115 waiver experiment. They said that it basically came to nearly $87 million in federal funds, and 54 million of that was just for the administration. And 90% of the administration costs were footed by the feds rather than the state. And yet that program was renewed. So as a lot of people look out ahead over the next year and starting in 2027, how do you contend with that? And if we're going to be spending more on this administrative process that some people contend will result in a lot of people losing coverage than we do on the coverage portion itself, how do you balance that?
So Georgia's not a great example. I'll answer the question, but Georgia has an unemployment rate that is so low that the need to take people getting off Medicaid and getting into commercial insurance has not turned out to be that great. But they're probably 50% of what they thought in terms of actual traffic. But you ask a related question that I do want to address more head on, which is the actual cost of adjudicating work requirement. So let me just take a step back. I'm just going to do a little thought experiment with everybody. If you're born in 1961, you will on average retire this year, right? So your sort of party's over almost. And so, sorry, if you're born in 1964, when you're 61 years of age, you will retire this year, on average.
I was going to say, I was born in 61, so, but let's move on.
You should have retired. No.
Back in the 1900s, yes.
So I just joined Medicare, by the way.
There you go.
Yes, I'm a beneficiary of my own program. I was born in 1960.
I was going to say, I won't ask you to divulge whether you are on traditional Medicare or Medicare Advantage plan.
I took Part A because it doesn't cost you anything.
And you get the government.
Because you guys are paying for me anyway. So so I took Part A so you don't pay anything. Part A is the backup now. But I'm actually not sure what I'll take. I have competing needs, including my wife that I mentioned earlier. But yeah, born in 64, you're going to retire this year. If we could get you, just that one age cohort, born in 64, to work not to 61 years of age, but to 64 years of age, or even 65, it's worth more than $1 trillion to the U.S. economy. The value of this most beautiful safety net that we have in Medicare, and Medicaid, by the way, as well, in the exchange and CHIP, the beauty is we get people healthy so they can contribute to society. That's the unbelievable return on investment. $1 trillion just by getting one age cohort to work 3 years longer, which if they felt vibrant and vigorous in life and fit, they might want to do that anyway.
Well, there are a lot of people who also need to do that because they can't afford to retire.
Yeah, but there's many reasons you might want to do it, but I don't want your health to be the reason you don't do it. So aspirationally, I would make the argument that if I can get you feeling good about life and you don't have a chronic illness, and I've made it easy to be healthy in America, which is part of the MAHA movement, which we should touch on, then we actually could get people to generate a lot of revenue for the country just by going to work. And so as I look at the work requirement, it is part of this administration's passionate desire to get people to believe they have agency over their future, that what you do matters. If you sit at home as an able-bodied person on Medicaid, and on average, you will watch 6.1 hours of television or leisure time at home. You actually don't want that. Opiate use rates skyrocket. People don't want to sit at home doing nothing. They want to have opportunities.
That's the example that you bring up. But there are a lot of people who are in Medicaid who are working.
Yeah.
A lot of this paperwork becomes very burdensome and difficult, and there have been people who have been disenrolled even though they actually still qualify. Yep. There are a lot of people who are on Medicaid who are there actually as caregivers. So they are working. They just don't have an 80-hour job outside the home because they have, a 24-hour job inside the home. So, I mean, what percentage of people really are sitting and just living off the dole and watching, playing video games for 6 hours?
The number I gave you actually was a published number from a think tank, easily identifiable, and it's, I'm sure, been searched quite a bit. But it's one of several bits of data we have that we can get people, and let's just say it's 20% of who's on Medicaid, or take that thought experiment, who might want to do more than what they're currently doing. So our job, and this is my responsibility with our team, and we've focused on this a lot, we've already run 2 pilots on this, is to figure out in an affordable way, because we pay the bill. The federal government picks up 90% of the tech technology tab of a state. So it's our money, your money that we're spending. So how do we actually get people not just to adjudicate that they are earning money for 20 hours a week, but if they don't want to go to work because they want to do something else, that they can contribute by taking care of a loved one, volunteering, getting an education. And here's the real opportunity. I don't think, and we're not satisfied with just proving that you worked enough. That's not the goal here by itself. The goal is to say, okay, you're an Uber driver in the gig economy. We just got ADP to adjudicate that you worked 18 hours last week. How do I get you 2 more hours of work? Well, we know you have a license and you drive. So is the state employment agency able to find you a job that might want a couple more hours of help? It's to match you so you can do the things I just discussed. Not just to keep tabs on you, but to elevate you, because you're not going to be able to make a good living at 18 hours a week. But if you're making a 40-hour-a-week job that has a commercial health insurance, that's better for everybody. And that's the bigger goal for us. Get people to feel comfortable that we have a hand up. Now, there are people who were in the workforce who got sick, who need Medicaid to recover and get back to work. And I remind my team frequently, there's a wonderful story about a hospital, it's called El Cid. It was the oldest hospital in the world for many years, and it was in Egypt, in Cairo. When you left the hospital, they gave you money. Why? Because you're not making money when you're sick, and your family's probably destitute, and they realized the goal was to get you back on your feet again. So they literally gave you currency equivalent the hospital was built 1,000 years ago. That was the history of humanity. Hospice was a place you went to die, right? Hospitals, hospice. So the goal for us is to get you back on your feet and get you back into the workforce. If we can achieve that, that's that story I was telling you about being born in '64. That's the real benefit to the healthcare system. So when people lament the fact that prices are going up, we don't mind paying 9% cost increases if, along with that, you get a huge bump in GDP because the value is so great. What we don't like is poor quality care at an expensive price when we're not getting people back to work. America's getting sicker, not healthier. There are many drivers of that, and some of them are not going to be addressable within the healthcare system. But we have to make it easier to be healthy in America, especially for moms raising families. We have a drop in so many metrics that you know as well as I do. But if we can address those underlying themes and we can manage chronic disease better, and one last theme, a better strategy for end of life, we actually can very, very confidently, I should say, address some of the cost concerns.
Before I open it up, when you speak about that, one of the sort of miracle drugs right now that everyone's talking about are GLP-1s and how they have so many applications. Obviously, they're very expensive. The last administration had talked about opening them up to people. Obviously, it's a big upfront cost, but ultimately, because it makes people healthier down the line, it might pay off. What are your thoughts on making GLP-1s available for weight loss in Medicare? Can we afford it, or can we afford not to do it?
It's the only question I'm going to have to punt. We're in the middle of a lot of action in that space, but you'll be hearing more about it very soon.
And all right, so moving on
These are, as you know, these are market-moving discussions.
Exactly.
So the best thing to say, everyone's looking at it. There are many options out there. The data on GLP-1s is published and much more coming out on it. So as a physician, I'm intrigued. We just got to find the right way to do it.
And speaking of GLP-1s, one of them is on the list for 2027 prices in the IRA negotiations. How are those going? And how do you see that program evolving? There are people who said Part D for next year is also seeing more out-of-pocket costs, higher copays, because in part of the PBMs trying to deal with this new cohort of drugs that starts with IRA pricing next year.
So the IRA, just to get everyone on the same page, was designed to allow government to negotiate on drugs that have been out on their patents, still patented, but on their patents in general, for enough time that the companies would have recouped their investment, so they'd stay innovative. But it would allow us to negotiate pricing that would be protective of the, in particular Medicare population, but in general, had some benefits. And the first year was a little bumpy as they were getting their, the team was trying to figure out how to best negotiate these issues, and that was before I came in. And so I evaluated that experience, and I said, well, we have 15 more drugs coming in now. And this is an important part of the quilt that we're going to weave to address price in America. And so the team has been aggressively negotiating. Their results will become apparent in about a month. I have tremendous confidence in them. These are folks who have gotten very much into the weeds of why drugs are priced the way they are priced, and are understanding of the need for these prices to be more in line with the important value that they all provide. These are the biggest, most used drugs in America, which is why we evaluate them. I believe by the time the president's term is finished, and I made this commitment to him, that 95% of all drugs in America will be at pricing that we feel proud of. Pricing that reflects the fact that we're not being taken advantage of. And I think the IRA is part of that.
So the IRA, MFN, what about PBM reform?
PBM reform is important in some of these areas more than others. There are things that PBMs have been willing to compromise on. I don't think that they're wed to the rebates as much as they used to be. I don't think I know. There's direct discussions. Trump RX, which is an opportunity to provide a marketplace. It's not going to sell drugs. It's going to create a marketplace. It's going to point you to where you should go if you're on this drug that might get you the best price. Your local pharmacy, an online vendor, maybe even a PBM could be involved in that. But that will force transparency into the system. You will know exactly what your drug costs, no matter who makes it, and you'll have options of where to buy it from accordingly. So I think that'll also bring an extra level of transparency into the PBM space. For the PBMs, there's many different ways that they can make money, but there are many things they do that actually help the system as well. So like all the other parts of the entangled ecosystem, part of our goal is to make sure that the garden is free of weeds. You know, take out the plants that shouldn't be there and just let the ones that are there prosper. And ideally, they should all be helping each other. They shouldn't exist.
All right, well, I'm going to open it up to questions now because I know there are plenty, and I think
Wow.
Ruth is going to do that.
Let's go. And a reminder, please identify your name and identify your affiliation. We'll start right there.
Hi. Shami Fineglass, a fellow physician at Manat. And Dr. Oz, I want to thank you for the rural health transformation, as well as just always keeping your focus on the health, mental health of all of the beneficiaries and putting the patient squarely in that. My question is really about AI and what incentives might be put in place at CMS to move forward with AI that's going to help quality, patient safety, and overall health for the beneficiaries.
So we launched a digital health transformation program under the leadership of Amy Gleason, who was in the first administration of the United States Digital Service. And we signed up 60 of the leading tech companies, all the AI players, at a White House event on the 30th of July. We've had 400 more companies come in now, all of whom have pledged. Not all of them are in AI, but they're all in health technology. There are a couple things they need. They need to know that HIPAA will be used appropriately, that patient confidentiality matters, but it won't be used as a weapon against them. They need to feel like they have a place in the financial ecosystem as well. So for example, how do we make it clear who your doctor is, who you are, so that you could actually engage the AI enhanced tool? And then would be a marketplace where they would actually be dealing with patients as their primary client, and we'd find some mechanism, for example, of reimbursing tools that result in outcomes improvements. So if you have an A1C of 7 and your creatinine's 2.5, it's worth a lot of money to us to get that under control. And if an AI instrument, an empowered instrument, any kind of, it doesn't have to be AI, but any app itself can deal with this issue in a productive way, we want to make sure that it was worth your time and investors to put money into your business to be able to do that. And I think that's part of a larger play here, which is how do we use AI to make the whole system function more efficiently? You know, some of the adjudication on prior authorization, what's the right bill to pay, what's the transparency issue in the hospitals, you actually know what you're buying if you do come in without an insurance protection. These are all the kinds of things that we think AI can help us with. But it also, part of it is, you know, the government has to tell the AI companies we're open for business. Right? If they don't think they have a willing counterparty, why would they have? They can go fix banking, make it work better. So I tell every group, and I have spoken to quite a few groups who have tech-heavy attendees, that we are open for business. We're looking for people, literally, by the way. If you have folks who are involved in health technology, we're looking for more people to bring in. We're in a growth phase with the digital transformation. All the infrastructure tools that have historically made the marketplace a rigid one, gummed it up, we're addressing those one by one because it's hard for private sector to do that, and they don't invest. And when they do invest, they invest at valuations that hurt the innovators. So we want to make that system healthier and allow it to prosper, but we've got to do our work to make it easier. But we have deadlines at the end of this year and the middle of next year to allow some of these processes to free up, and you'll be seeing more digital tools with AI support available for the American people along those timelines. What kind of physician are you? What's your specialty?
Public health, internal medicine, preventive medicine.
Okay, so real doctor, internal medicine. but you know, AI is incredibly important for psychiatric issues.
Yes.
Because you know, it's hard for AI to do my heart surgery, but it probably is better than me at hearing your issues. I mean, think about it. Doctors don't go to medical school to give advice on diabetes,
If
right?
it doesn't hallucinate.
If it doesn't hallucinate.
Because we have seen those cases where
It does. We have having talked to these folks, I do believe we'll get better at that, not worse. It'll take time, and we don't want you giving horrible advice that's completely hallucinatory. So they have to have some guardrails on that, and maybe be more limited initially. But you know, if you're giving the same advice every day, eventually you don't do it as well. You're not as kind as. And so the data that I see on AI having the initial interaction versus you actually shows people prefer the AI. It spends twice as much time. It's more patient. It gives the same advice the same way every time without getting bored. And clinicians do have that problem. You know, at the end of the day, you're exhausted. You rush through you don't want to work up the cough. And if agentic AI can get the X-ray, adjudicate if your insurance covers it, make sure the pharmacy's going to fill the prescription, the sputum sample's set off, the white count's normal, and then calls you with all those answers when you're home having dinner with your kids, you'll stay in practice. And that's another big issue is, doctors don't retire because the job is hard. They retire because the job's bad, right? If it's not a good job to do, we don't go to med school to do paperwork. And kill the kilt board is a big part of the project for that's an apolitical statement I'm making. None of us go to medical school to fill out the paperwork.
We've got time for a couple more. Yes, right here.
Thank you. My name is Becky Wolf. Thank you so much for coming to talk today. I'm a graduate student of public health at George Washington University here in DC. And I was interested in your point earlier that there's a lot of folks with ACA subsidies who aren't aware that they have coverage and how beneficiary outreach and education is a critical issue. So in terms of thinking about all the HR 1 changes to Medicaid, such as work requirements, 6-month eligibility redeterminations, and cost sharing, how will CMS help states ensure that beneficiaries are aware of all the changes and the administrative burden they'll face?
Thank you for the thoughtful question. It is historically been very difficult to get folks to sign up for the ACA. I think a lot of folks don't believe it's real. If you look at the ads, and I have to go through the ad campaign, we spent $150 million last year, $150 million on ad campaigns just on the ACA. That was more money than the copay of the people in the ACA. So you realize that we're not getting our money's worth because most Americans who are in that group, and many of them are young Americans like you who think they're healthy enough, they don't have to worry about it. Even if it's free, they don't want to bother with it. So we need to change that dynamic. We're looking at different mechanisms of messaging, maybe different than what we historically have done. What works for Medicare doesn't work for the ACA. But also, we do rely on groups, community activist groups around America to go out into the community and tell people. And those groups haven't really been empowered as much as they could be. The gentleman who's going to come in and run Medicaid, Dan Brillman, who's probably, I'm hoping, we're desperately waiting for him to come in, but there's a hiring process. But he had a business that actually was tangentially related to this. So he understands the space fairly well. How do you use all the different community groups to work for a purpose? In his case, he was focused on Medicaid in particular, but we could use it for the ACA as well. Those models already exist.
I think she was asking about Medicaid in the sense that there is going to be so much upheaval in terms of.
Oh, I thought you were asking the ACA. I'm sorry. Yeah, yes. I thought you were asking about the ACA, and you mentioned that Medicaid was going to push more people into the ACA.
I'm curious, how those learnings can be applied to medication.
Oh, got it. Perfect. Thank you. There's a lot of transferability of that information. I apologize. I should have listened better. See, you're a better listener. I'll give you a stat that I've heard from FQHCs, which I adore, and I think we have to find better ways of getting more internists and FQHCs and growing them. But they tell me that when they book...
FQHCs, just explain.
Yeah, I'm sorry, federally qualified health clinics. These are...
Community health centers.
Community health centers. Yes, they don't have to be federally qualified, community health centers. So when I go visit these centers, they tell me that they have to, their anticipated cancellation rate for a Medicaid patient is twice as high as a Medicare patient, which always sort of caught me off guard, but it sort of makes sense. Medicaid patients it's harder to get health care. They have jobs that aren't as forgiving. They don't have transportation. They've got other people crutching on them. Sometimes they don't value themselves. There's lots of reasons, but they miss their appointments. And these are really important appointments to deal with underlying issues, many of the mental health issues. So how do you get that system to work better? One way is once you get them at the appointment, do all the things you need to do. Like, do the internal medicine checkup, but also get them the mental health consultation, do the pharmacy reconciliation, maybe they're in substance use disorder clinic, get that all done at the same time. So once you get them, get it all done. And these are one option. The other is I really think we should be helping the community health centers to work more closely with hospitals. If I was running a hospital, I would put a community health center across the street from the ER. That's a better place to get care. And there might be ways for us to use the larger footprints to help the smaller footprints, which I think would disproportionately help Medicaid patients.
Time for a couple more. Right there in the black.
She checked the, that's beautiful. What color do you think you were wearing today?
It's black, isn't it? Yeah.
My name is Margot Singer-Katz. I'm a reporter at the New York Times. I also have a question.
No relation, just to be clear.
That's right.
I also have a question about the Medicaid work requirement. You had mentioned in a letter to states a couple of months ago, and I think you just mentioned in your remarks earlier, that CMS is developing a tool to help states do the work of figuring out how much people are working and how much they're earning. Can you tell us a little bit more about that project, where it stands? Is it going to be ready in time for the rollout of these work requirements?
Sure. Your first name is Margot?
Margot, yeah.
Yeah, so Margot, there's a couple different layers to the process that's called upon in the One Big Beautiful Bill. And it's really not work requirement, it's community engagement. And so to do the community engagement, you have to create rules engines, which we have done, that tell you, or any software developer, what are the rules for work hours? Like, how do you have to actually adjudicate it? For example, what if you're paid a salary but there's no hours on there? So we are going to adopt a process, right? Maybe, for example, we'll divide the hours, the salary you have by $15 an hour, minimum wage, and then we'll just give you credit for that many hours. So we have to do all that, but we also have to figure out, what does it mean if you're at school half-time? Like, how many hours is that? And then if you're doing community engagement, who's allowed to credential you for community engagement? Do they have to be a 501c3? There's some work around that. So we've been spending a lot of time on that. Meanwhile, we did 2 pilot studies in Louisiana and Arizona, about 25,000 patients. And we wanted to know if, especially if you're in the gig economy, because people on Medicaid generally don't earn W-2 income. So you have to be thoughtful about where their money's coming from. And so if let's say you're an Uber driver, again, using that same example, we would ask you, okay, we know since you drove for Uber, these are the different ways that payroll would be done. ADP is yours. Click this box. Let us ask them if you actually worked at Uber this week. And with your permission, we then we get the numbers back. We know that you're 5 hours short or whatever the number is. Then we query you about other things you may have done. And this process worked fairly well in these 2 states. The satisfaction rate was about 85%. The time to complete the document was 7 minutes on average. There were some, but again, it's 85% happy, 15 not happy, probably didn't get good results. So that's not good enough. You can't have 15% of people lost from appropriate Medicaid coverage because it didn't work. So we are working on making that better. It's not just going to be a government-built one. We are also aggressively interviewing. I met with all of the major state platforms who provide services, including community engagement possibilities. I met with all the insurgents who want to replace those guys. And they have very good arguments. The incumbents say it's too dangerous, you can't come off our platform, but the work orders, who's built a house here, by the way? That the work order changes are shockingly expensive. The insurgents have much better ways of doing it, but can they really scale? Can they do it? We can't afford for it to fail, Margot. It has to work. And just to put a date on by the end of next year. Now we have the ability to give states freedom to if they really are trying and it doesn't work. But ideally, by the end of next year, states will have workable programs. But I have the additional aspiration that I alluded to earlier. If you aren't at the numbers you need to be at, we don't want you dropping off Medicaid. So things we're thinking about, these are all, I'm not committing to any of these. This is an open discussion, but things just to show you that we're trying to do our work and our homework. I'd love to be able to give you a hand up, point you in the direction of services that could use you so you can fill out the rest of the hours. I also think that we have other opportunities to take folks who, if for whatever reason they fall off the rolls, we should have some mechanism to give you access to pharmaceuticals at the best prices possible so that you don't pay more than everybody else. And also, of course,
On the cash market.
on a cash market, which is not ideal, but there will be possibilities there, because that's the real gap. God forbid you have an emergency, you could get care, and retroactive emergency Medicaid, not a good way to do it, but I'm less worried about that than people on life-saving medications not be able to afford their meds. So we want to be cautious and conscious of that, and that's why Trump RX and other tools may be helpful there.
To Margot's question, though, where are you in that process to be able to have those systems up? Will there be an app that people will go to in every state?
The goal would be to give states several options. I'm going to put the number up there, 4 options. One will be ours, but at least 4 other options that, and we'll say we'll negotiate the prices because we don't take an advantage of. Again, we're paying the bill anyway, so I don't want to go through the purchase process. That tends to be slow. It's not always seamless for states. So we're going to give you a couple options. It's like walking into a diner. Pick the one you want. You want the eggs, you want the pancakes, here's the pricing. Pick the thing that you think most readily works with you in your system and the current platform you have that would fit in like a widget. We're negotiating, as I mentioned, those prices because some of these are incredibly expensive and states have been priced out. We don't want that happening. So by making it as seamless as possible, get it up on its legs and get it going with a product that works. And it has to work with that short and efficient. And when I say efficient, I mean, I want people to succeed. And if I tell you, go work 2 more hours to get your health insurance, well, I think that will help us deal with the moral risk of having 2 twins, one flips burgers for $15 an hour, barely makes ends meet, but does it, and the other doesn't work because it's not worth it. Because then you actually lose the incentive. I want everyone to know that if they work, it matters. It'll matter for them long term as well, but it matters for the system and it matters for our country.
One more, and then Dr. Oz, I'm going to give you the last word.
Okay, I do have to go back to work, by the way. How long have I been
One
here?
more. No.
Is that
I'm not
clock
gonna-
working
no,
back
no.
there?
I haven't picked on a guy yet.
Yes.
Here we go. Right back there.
Thanks so much, Dr. Oz. Keith Martin, the Executive Director of the Consortium of Universities for Global Health here. We know NCDs are going to break the back of the system, right? So let's take a look at the equation on the other side.
I missed what's going to break the back?
Non-communicable diseases.
Yes, yeah.
So let's look at this equation on the other side, the prevention side. Could you share with us, please, your views and vision of how Medicare and Medicaid could perhaps be used as a financial tool to be able to invest in known public health interventions that can not only vastly improve and reduce mortality and morbidity data here, which is really bad amongst OECD nations, but also save a tremendous amount of money for the public purse. It's a win-win-win situation for everybody. And finally, any comments you can make to Secretary Kennedy on strengthening the CDC would be greatly appreciated, because he's, I don't need to say any more about that.
Thank you for the question. So chronic illness drives probably 65%, let's just say 2/3 of all healthcare expenditures in America. So your question is right on target. There's 3 buckets, and this will be my last comment, so maybe I'll just spend a second on this. So the first bucket is, how do we make it easy to be healthy in America? I touched on this earlier, but this really is the MAHA movement. And what does MAHA really mean? To me, it's one word: curiosity. Now, today you've heard a unique experience because every one of the questions is really a question, but as you know, probably 80% of the times questions are statements in disguise. So actually having real questions like this opens up lots of opportunities to learn, and I learned from you as well. But in the MAHA movement, if you ask those difficult questions and you're curious about them, are you courageous enough to share what you've learned and start to deal with some compassion with those issues? So we want that to be a strong part of this. Much of that is outside the CMS mantle, but we work very closely with groups that are, obviously CDC being one, that are trying to aim at those. And AG and the like and the other agencies, HUD, are actively involved in those. Second big bucket is the chronic diseases, non-communicable diseases, as you call them. And The majority of these are actually caused by obesity and similar lifestyle-related decisions that Americans are making. And we do have some opportunities with the GLP-1s, and there are many more coming out that are actually pill-based, so you don't have the supply chain issues, the cold storage and the like, that makes it also more affordable. But the obesity is not a shortage of GLP-1s. Obesity is a reflection of much bigger pathology within our ecosystem, where we've subsidized foods that aren't so good for you, directly and indirectly. We have not taken seriously the threat of some of these lifestyle changes, especially to our young, when 3/4 of Americans can't serve in the military because they're not fit enough. These are all things that we as a nation need to grapple with. And there is an element of purpose that comes into play. Most people that I talk to that are, out of sorts often are having an ongoing existential crisis in their mind about, like, why am I here? What's this all about? And they're not able to make peace with all those elements, and they don't respect the temple of their soul because they don't realize how precious it is. It's the most valuable thing you were ever given. And so getting people to respect that reality and partake when the options are afforded them, which I'm hoping, again, will meet people where they are, which is probably the best way of dealing with chronic illness. I think I have hopes for. That's why the digital transformation and the AI question earlier is so important. It's hard for me to meet someone who's depressed and eating because the only thing they think they control in their life is the fork at the end of their arm. And so they use it. And they use it in ways that are incredibly effective with foods that comfort them, at least short term. And we need to take that risk, that threat seriously, because you can't put the genie back in the bottle after you've developed renal failure, you had your first stroke, and I'm trying to catch up all the time from behind. The third issue, just to end the discussion, perhaps appropriately, is we need to respect what aging is all about. We just don't do that well in America. And end-of-life issues are pushed to the side, and even the way we fund end-of-life is not really sort of this bizarre mishmash quilt of services that don't actually play well with each other. They're not incentivized to play with each other. Hospice and long-term nursing facilities and in hospitalization, and they're almost at odds. Their MA plans can't send to this, but they can send to that. So they, PACE. Why would PACE not be supported by MA? PACE program for the, what's the A stand for again? Well, whatever. Yeah.
Hospital at home.
Yeah, hospital at home, another example. PACE is to keep people who could be in long-term care at home for longer.
It's
and
a
so,
community-based program.
yeah,
The key thing.
and they're actually under-supported. The Unlock, which is this beautiful program in San Francisco, has a census of under 200. It could take 50 more people, but they can't get patients referred from Medicare Advantage plans because it would be cost prohibitive. I mean, it doesn't. These are big things we can do better on, but that's part of my job. Secretaries ran the whole thing, the whole program for 4 years. It's not easy to do these things, but if we don't take those issues seriously, those payment incentives, we won't get people to work together. But at its very core, we are incentivizing exactly what we are getting. Everything you see around you, we have incentivized it to be that way. And so either people who wanted it to be this way did it and got away with it, which is why sometimes people don't like me, because I didn't come here to stay forever. I used to be where you are. So I come do what I can for 4 years and then move on. So it's okay if I take some hits along the way. But we also have to be sophisticated and thoughtful in how we redesign the system's incentives to address some of these issues. And some of them are easier to deal with than others. And you don't often have a plan B, which is why we're stuck with plan A, which doesn't work so well. But with the help of people like you in this room, I love, and the good ideas that we keep hearing, I think, and I'm optimistic we'll get there. And much of it because it's a remarkable coincidence in time. We have a generational opportunity to do something that I don't think could have been done earlier, but let's not blow it. We may not get many more. God bless you.
Thank you, and I hope you'll come back to continue the conversation. This was an extraordinary conversation. Thank you.
Thank you so much.
Appreciate your questions.